It was a good interactive discussion last time we had, and of course there was a lot of lead up to this session because we already had a few questions regarding what we're going to talk today. So let me just start sharing my screen already. All right. So today's session will be focused on communicating bad news or serious illness, as whatever we may call it. There are some models, formal models of communicating bad news. We'll go over that briefly. It will include what is the need for communicating with, being so formal about communicating bad news and how to do it. Dealing with collusion, which we also hinted last time, and then dealing with emotion and anger. Sometimes, these days we have angry situations concerning patients or their relatives, and how to best deal with those situations. Like last time, if you have any comments, questions, just keep putting them in the chat, and myself or Senior will keep a watch on it, and we'll deal with them as and when we stop in between. So what is the ideal method? This is obviously, as everything, we don't have the last word, because a lot of these things are personal, cultural, health literacy based. So these things may not be universal, but we try to have a common model, and then obviously we have to individualize it, and also make it sensitive to the cultural practices of our own situation and setting. So there are multiple factors, as I said, in cultural issues. There are different, all over the world, we have different communities. Some communities are more individualistic, focusing on the quality of life. Then quality of life, there are some community, they are very interdependent, joint families. So the decision making is not independent or individual. And there can be other things like, giving more importance to longevity in whatever way is possible. And talking about death is a taboo in many societies. And as you must have heard, even when we growing up, and you talk about death, and your elders will say, no, don't talk about this, that's not good. So this is changing. People want to know more and more. There are more expectations. The bucket lists are growing, and people have formal things what they want to do, so they would want to know more about what's happening in their life. But basically, it means that we have to have a right balance between the rights of the patient, the rights of the family, and family's anxieties, and what is medically correct. So one thing we need to say is that if we know that patient has the right to know, if they ask for it, patient also have the right not to know. So if the patient is not wanting to know, you can ask them. The best is to know the patient's desire. Who should we be talking to about all the plans and diagnosis? A lot of them would want to know everything. There'll be some people who will say, tell it to my husband or wife or son or daughter or brother. So we need to respect their wishes. Either way. There are many models, like full disclosure model, where a patient wants to know and you want to give the whole information. It is very critical. It concerns life expectancy and all. There are partial disclosure models where the patient does not want to know everything, and they just want to know what is the current plan or something like it. And non-disclosure, when the patient doesn't want to know, and then they depute somebody that you talk to the family, or this. I'm sure there'll be questions. The question comes when the patient is not in the picture and the family is trying to discuss. So that is a bit complicated. We'll talk about it. So before that, we need to know, and if we know, we will be able to talk to the family who comes and tells, don't tell our patient. We have to tell them, we have to ask them what is their worries, and what are the benefits of patients having at least an idea if there is a serious illness or life expectancy is limited. So they may have closure of some life's business. Somebody wants to marry off their children. Someone wants to write a will, wants to travel a world, as I said, the bucket lists. So if they don't know that they are slowly withering away, that'll be very sad for the patient. They'll go hospital hopping, doctor shopping, because they don't know the diagnosis. They've been just given a very vague thing and they thought that the doctors don't know, since the patient doesn't know. So these are the barriers, and we need to, for our absolute care, we need to be as close and honest with the patient as possible. So what is the right way? So if the patient indication is patient wants to know, of course, then it becomes much simpler. And, the best ways to ask this, I try to do is, before we have serious news to give, like patient comes for a procedure, in my case, it's electrophysiology. I don't know if the patient has a normal nerve damage or it's a motor neuron disease, which has no cure almost. Or in cancer patients, we don't know before we get the biopsy report. That is the ideal time when we can actually get their viewpoint on it. What kind of and how much information would they want? And then they can either say, I want to know everything, you tell me directly, or they'll say, talk to so and so, and whatever happens. So even then, we give a warning shot, make a serious mode even when the patient wants to know, so that they get another chance. If they're really not interested, they may see it coming and they might just say, okay, I mean, maybe today you talk to my attendant or something. But if the patient confirms, then we do the narrative approach. And this is what I was talking about, the formal communication of bad news strategy, which is called the spikes method. There are other few also, but this is the most commonly used. I think it was developed by MD Anderson Hospital. And it has been taken up by many communication people as a good model to do the communication of serious illness. Basically acronym which stands for SPAKES, SPI. So the S is for setting up, as we talked about in the last talk about having undistracted and Dr. Sunil also showed some videos. So uninterrupted, we need to do this in an uninterrupted, whether we're talking to the family or we're talking to the patient, we need to do it uninterrupted way. Maybe in a room, separate room, where we can sit on chairs, comfortable in a reaching place where you can comfort the patient if required, and not distracted. Phones are off, there's some water around, sitting positioning, all these things need to be taken care of. The second thing is patient perception, which we were talking last time, and I talked about in the last slide, that we need to know, actually we need to know how much the patient knows. Sometimes the patient has read the report and they're just not talking in between the family because, it's uncomfortable. But if you ask the patient, what do you know? They might just tell you that I know I have cancer or something like that. And then you don't have to make all those things up. So it's a good idea to ask the patient, so what is your idea about your illness? What do you know and what do you think you have? And if they don't know anything, we have to be more careful in slowly breaking the news. And if they know everything, we may start from the next step. And the next is the invitation, of course. We already talked about it, to disclose to whom, to when, to how much, and the patient, and we go according to the patient's wishes. Third is giving the actual knowledge. Like we saw that clip last time about being, giving medical jargon and to talk, and people being overwhelmed, they don't know. So the knowledge has to be given in small amounts. We give them time to assimilate, what we call chunk and check. So we give them time to assimilate this, and then give them it in their own language they understand. After this, I mean, there will be emotional reactions many times, and they will have questions. Some of them may repeatedly question. We have to be ready. We have to be very empathetic that time. We can sit, we can talk to them, maybe even hold their hand if it culturally allowed, and then let them time to assimilate the news. and try to support them through the emotion, like we said last time slides. Do not negate their emotions, but actually legitimize the emotion of being weak and vulnerable. It's all right to feel this way. It's okay to cry if you want. We can wait. I can give you a handkerchief or whatever, tissue paper around, and then just spend some time. And the last is strategy, basically plan for the future. So this depends upon the urgency and the patient situation. The patient is extremely emotional and is not ready. And there is nothing urgent to be done, like operated or chemo the same day or this thing. It can wait. We sometimes tell the patient, okay, this is the printed information. You can go read up, come back with the questions, and then we'll make the plan. So depending upon the situation, we can do it that time, or maybe fix up another meeting to plan the strategy. So this is the gist of the breaking bad news protocol. And then if need be, have 5 minutes out with the patient or their attendant to maybe just be with them before we walk away. Just don't throw the news like a bombshell and we walk away. That is not good for the patient. So once the emotional state is subsided, as I said, you ask them any further questions, they can come back with the questions. And they may have many questions about the curability. If they already know the diagnosis, treatment options, cost involved, future plans, as I said. So all these things will be there to answer, and we should be tentatively ready. And if we don't know the precise answer, we can be very honest that, okay, these are the answers. I will come back to you with those. We don't have to guess that time. So this is a simulated, let me know if you can't hear it's mainly verbal. So this is a simulated thing we made about, along with one of my resident doctors, Dr. Abir. He was nice enough to act a patient who thinks he has a mild nerve illness, but from reports we found they have motor neuron disease, which it's inexorably progressive and many times severely debilitates a patient, even leading to the demise sometimes. So this is how we have enacted this situation, and I've put up those few markers on top of it. What are the issues we are wanting to talk about?
Kaise ho? I'm good, sir. In fact, the last medication you gave me worked wonders for me. My twitching has improved by 80%, and regarding my muscle weakness, I'm feeling improvement in that too.
Yeah, I have your reports here. उसके बारे में बात करेंगे. तुम्हें क्या लगता है अपनी बीमारी के बारे में, क्या फीलिंग हो रही है? कुछ आइडिया है?
No, I think last time we had discussed about that. You told it's some weakness in the nerves. So, in fact, after taking the medication, I feel it was just because of after my fever. So, I guess I'll be back to my full power in another week or so.
Okay, we actually will go into the reports. Do you have somebody with you want to call in, or you want me to explain everything to you, including the diagnosis, the prognosis, and what is going to be the future of this illness?
Oh, no, I have come alone. You can tell me what's the matter.
I'm saying so because unfortunately I don't have very good news based on these reports. It's true that it's a nerve disease, as we discussed last time, but after doing the electrophysiological test, we have come to a diagnosis which we call as motor neuron disease. It is a nerve disease. It affects the neurons and it makes them weak, and sometimes they degenerate. The problem is that this disease is not a short-term disease. It's a long-term disease and usually progresses over the coming days and months and years.
You must be mistaken here, because I just have a very mild symptoms of bit weakness, a bit twitching. That guy, I guess, was wheelchair bound, and I think there must be a mistake here.
We can repeat your test anytime. It's not a big test, but from the reports we have now and our electrophysiology team we have discussed, we are not much in doubt that it could be anything else apart from motor neuron disease. You don't have to be, everybody with motor neuron disease does not become wheelchair bound immediately. that was the later stage of disease which we see in Stephen Hawking and all. But in early type, like you are likely to be physically active for quite a long time.
Yeah, that's what you need to understand, Doc. I have just been married. It's been just a month. Okay, and all this while, on all these 30 years, I have just been, looking forward for earning, and taking care of my family. It's my time to enjoy my life, and I don't think so. I'm ready for this thing right now.
I know, I can understand that. I wish I could tell you things were better than this, but we could sit and discuss what are the possibilities. It may not be a cure, but which can support you to move and be ambulatory or keep moving and keep working for a longer period of time. We don't have to do it now. You could come back and we could think about what all the medications we could be using.
Yeah, definitely. I think it's too much for me to take right now. I think I'll take some time to.
कैसे हो? So, sorry. So, were you able to hear the? Hello?
Yes, sir.
Okay.
It is clear.
So before we go into the merits, and we've already actually talked about the things which we were trying to show, can someone point out the miss? Because I made it a few years ago when actually I started doing this communication thing, and having a doctor in front of me wasn't the real situation. So can someone point out there were some things which I said should be happening but didn't happen in this conversation? Like either giving proper knowledge or giving it concisely, or taking patient's reaction, or not using medical words or anything like that. Did you notice anything which was off the mark, which I realized after making the video? Yeah. Okay, yeah, identifying emotions. He did not show too many emotions, so that was something which is missing in this video. But if you note, someone wants to talk. Do you want?
You gave the example of Stephen Hawking.
Mm-hmm.
And वैसे तो सही है, it is right that when you're giving a diagnosis that you give that is the patient, but when the patient is receiving this diagnosis for the first time and the picture they have is of Stephen Hawking when they're receiving it, I don't think so they would be able to deal with it very positively when they receive it.
Yeah.
So I think that was one thing which could have had been avoided, at least on the first time when he's been given the diagnosis ki you have this particular disease.
Yes. So you spotted it point blank. Actually, we edited it, but still there is a reference to it. So we realized after that. But the other thing which needs to be changed, I think Sunita has pointed out rightly, is I used medical jargon in this a little bit. Neurons, prognosis, so that happens when you see a neurologist sitting in front of you. You start using, I shouldn't be using the language of what do you call the medical language, as you said. So these are the two things which needs to be changed in this video if you want to make it ideal. Otherwise, I keep showing it so that people can pick up things which are not ideal. So let's go ahead. Thank you for your responses. So this is the collusion part. Collusion is which somebody was pointing to last time. You just need to give me a second. I'm just getting a message from the hospital. Just give me 1 second. I'll just put it on hold and, share it. So this is the important part where, that collusion is when the family is trying to protect their loved ones, but actually may end up harming, not always wrong, but the thing is they may end up not serving the best interest of the patient. They are also mostly doing out of love, but they don't tell the patient, and they ask you not to tell the patient, and it becomes a very dicey situation. As I said, if the patient approaches us first, the best thing to go around this problem is that we directly deal with uh, the directly deal with the patient and ask them who you want to tell. And then if the patient say, I want to know everything, then our work is very easy. But if the family only approaches us and we need to talk, there's no point going against them. They need our help and we need their help for the best. Sometimes the family is spending the money, the patient, it's very common in our setup. Parents have given up everything to the kids, and the kids decide. It can work both ways. I mean, if they have to spend money, they need to know, and also sometimes they may not want to spend the money. So it becomes can become a bit of a sticky situation. Mostly people act out of goodwill when it is concerning their close family. So that is a good part about it. We treat people as good unless proven otherwise. Because in 1970, some people, wrote that it is inhumane to disclose bad news to the patient. So the paradigms are changing. Palliative care is there. There are symptomatic therapies. Patient can live a good quality of life. Sometimes they would not want to take high dose chemo or anything because they just want to enjoy their life till they go. And so either the family knows exactly what the patient would want. Otherwise, it is best for the patient to tell their values in life. Of course, many times they won't tell us because, culturally they may be inhibited in saying that. But we need to make our effort best. Someone has mentioned that they are not able to see PowerPoint. Sinia, is the issue on my side or is it issue on their side?
Their side.
Okay.
We can see it, sir.
Maybe you can restart or something, try. So and there is a health charter. The government of India has also put up a draft patient charter. You can look it up on the net, where we are obliged to say a few things that if the patient wants to know, we need to tell them clearly and honestly. So best is not to challenge their belief, because if we challenge them, this increase their anxiety. We are forcing something on them. So we have to work with them. Many times we tell them that these are the benefits, as I said, which I'm telling here. We tell it to the patient relative that, how much they lose. Of course, if you want, we can tone it down. If you want, the patient, unless patient has real depression, suicidal, those things and all, then we take psychiatry consultations before talking to them, of course, about these things. But if not, many times it is a misjudgment that we will take it, our relative will not take it. People are usually able to take such news if given properly. That is the reason we are going through the proper way of doing this thing, rather than go in a stones kind of a thing, hit them with bad news. So this will calm their anxiety and we'll get a chance to give some relief to the patient. How to do this? When their trust is, give them some data. Like I'm showing here is a study about cancer patients from our country. And they tried to show that, to talk to people, how many people wanted to know their cancer diagnosis. And it was an overwhelming majority that they wanted to know whether it is cancer or not. And majority of them actually wanted to have a full prognosis, how much time they've left, what is the treatment, what can be done. So if we discuss this with the family, they'll be able to more understand, and most of the time we are able to break that logjam. But we sometimes, if the patient is not there and they are a little adamant, maybe we have to work with them to do it their way, in the way they want to give the hand. Many times the patient actually knows it. So asking the patient casually what they know about their issues is a good way. And if they know it, all these things, then we can tell the family, actually the person knows. So you can we can mediate talking to them, or you can talk on your own. So all these models are variable. You can see they are variable according to your local culture and practices. So, I'm sure there'll be questions regarding this. I think we'll take it once I finish these few slides upon anger management. Unless you have anything urgent, you can raise your hand and, Sinia, you can unmute them. I'll go on to this anger thing because, as I said, I have a meeting at 4 o'clock, so we need to finish this before, but we'll have ample time for discussion. So anger is a generally very high energy consuming emotion, and happens when we are in a lot of stress and we are unhappy and frustrated, which is not uncommon when you're in a hospital in a very serious circumstances. Things can happen. Even if you're a nice person, you can get angry. So that is what we need to understand when the attendants get angry sometimes. And if not managed at time, it can turn to rage. Rage is sort of anger stage where thinking capacity is bypassed, and that is where most of the destructive things happen, whether it is physical violence or abusive behavior. This happens, so we need to stop it. We need to preempt that this person is going into a rage situation. And so what are the best ways to deal about it? First is that if they are standing, you stand in front of them. We try to be a little respectfully standing, not in a very defiant posture. We don't have to react, we have to respond to them. Our idea is to let the anger flow away. So we need to listen, let them talk. Even if they're talking wrong, we don't have to say yes, oh, of course you're yes. No, if something is miscommunicated and they are blaming us for something, it is not our fault. We don't have to agree to that, but we can just listen to it and not react. Let them finish, then keep eye contact with them, not in a dominating kind of way. As I said, that eye contact in the eyes and then maybe waver there and here, like natural eye contact. But of course, our safety is important. So it's good to maintain a distance. And if we are really seeing impending violence, it's always good to have, depending upon the system in our hospital, security available or a bell available where you can call people at short notice, and better to do it in a bit of this kind of a talk where other people are around nearby. Once they have said it, then we ask them to sit down and agree to what they said was right. It may not be negligence or anything. It could be just that a bed is not available, ventilator is not available, and explain to them that this is the situation overall in this setting. The patients are more, machines are less. We are always trying our best, but the load is too much, and every patient may not get every machine possible, but we are trying to do whatever we can in this situation. So you're right that your patient is not got this or getting delayed, but these are the reasons for delay, and we'll try to do our best. And then correct the correctables. Of course, the whole part is that if there's something on our part which is not being done properly, we tell them to correct. We can also tell them that sometimes people are angry that you don't bother. The thing is the doctor is not bothered about it, or the healthcare professional, nursing, whoever, they're not bothered. They're not even bothered if they're complaining. So what we do sometimes is tell them that, okay, there is a register lying there which somebody else will read, not me. You can put it into that box, complaint box, and all the details, and somebody will have a look and get back to you about it. So many times just saying this, that earnestness to help the patients, diffuses their anger. So the 4 C's I talked about in the last talks, I add 2 C's while conflict resolution. The 4 C's are, we've talked about it, candid, concise, clear, and complete. And the third is calm. We need to be calm in those situations. Sometimes we'll be hearing something we don't want to hear. But the idea is not that we need to get even with them. Idea is to help them through that phase of anger. More times coming because of weakness and vulnerability in the hospital. And then find a commonality, find a common ground. As I said, okay, this can be done, this can't be done. You have the choice of shifting the patient. These are the facilities available, but this is what we can do. Now that you brought to our notice, we will try to escalate that. So find a common ground with them where we can work on these people. Okay, this is the end of the slides, and now we can, discuss any points or any comments, questions. You can raise your hand. We can talk verbally.
Thank you, Dr. Param.
Yeah.
If there is any questions, you can unmute from your end. or you can put it in the chat box.
Were there any questions in the chat box before? Maybe I missed or we dealt with them.
Actually, no. Till now, there is no questions.
Patient seated in a better chair than doctor. I think maybe it's a light comment.
Yeah.
Okay. Yeah. So yes, of course, the patient actually they should be sitting in a better chair, but this was because we were doing it in our lab, electrophysiology lab.
Sir, I
Hi,
need
Preeti.
a
Yeah.
little bit more about the anger management. If
Yeah, carry on. Anything specific you want to talk about?
No, we wanted some input from like how to manage if we are not if we are not able to control the anger from or the rage from the patient's side or the family when they
Well,
get that news.
as I said, the basic points remain the same. We can have views of the house. Also, I'm sure all of you are have been sometimes in these situations, or your teams have been in this situation. How we do it, you can put in the chat or talk. But I'll just try to say with something. So the basic things remain the same. Is let it flow, and then try to be honest about it. As I said, we don't have to accept what is we don't think is a fault, but because we may be told so many things without fighting back, we can tell, all right, you are angry, we understand, and some of these things maybe we can look into. The others are because of that, and maybe some are that your understanding is about that. This didn't happen. Your patient was not overlooked because of this, because this is all happening. Sometimes they may feel very urgent about the patient and not realizing that the situation is not that urgent. So all these things have to be told, and honestly, trying to resolve the situation is good, but time is very important. We don't have to hurry. We don't have to contradict. We don't have to cut them off. And in the end, of course, protect ourselves. If you think the situation is beyond, you can, you can see what is coming, and if it is coming to a violent thing or something, we have to be very careful, and we have to protect ourselves. I mean, I don't know if it answers your question, but if you had anything specific in mind, happy to talk about it.
I think that's yeah, how much as we can understand until and unless we face the real situation. Then
I know every situation is different. Every situation is different. So the basic tenets will be this, and you may have to on the spot modify how to go about it.
Yeah, spontaneity.
Yeah, the basic thing remains the same in every part, whether it's anger management or breaking bad news. True, genuine care for the patient, feeling for them, trying to be in their situation, trying to be in their feet, in their shoes, and being empathetic, and listening properly. I think that is the basis of all types. And then, of course, we have to build on that.
Thank you, sir.
There is Tanvi is asking how to handle situation where patient strongly wants to know the diagnosis, but the family is not willing after counseling. Well, this is a question very often asked. If somehow, as I said before, things happen and the patient has shown the desire, and you understand the patient is not, either demented or what you see, the incompetent patient for communication. So incompetent patient for communication is patient after the patient wanted the desire to know they've got stroke, they can't understand, they're unconscious, they're comatose. Of course, then you have to depend upon the next of kin, or sometimes if there's nobody, the court-appointed people. But if the patient is competent and they have clearly shown desire to know, I think our job will be to explain it to the family as much as possible that we are obliged. We cannot lie to the patient. If the patient is very clearly, doctor, I want to know, and please talk to me directly, everything about we are obliged to say. Then unfortunately, we may have to bypass the anxieties of the family. So we won't be ethically and legally right to hide from a patient who has actively expressed desire to know. I know it can be touchy, it can be the family can get upset or something, but you have to tell them separately that they are asking the question. And not that, it's not a simple question like if the patient says, okay, what is wrong with me? And then you have to take the consent that, can I talk to you everything? Whether it is good, bad, serious, And if they say, yeah, whatever it is, even if I'm dying, you tell me, I think then we are obliged. We really don't have a choice. We would like to have the family on with it. But if the family is not on with it, at least we'll have to pass it by them that things are not good, and I can give you serious news, and they say, yeah, carry on, then we may have to do that.
Thank you, Dr. Param, for that reply. We have Vaishali Ghosh raising her hand.
Yeah, please, Vaishali, carry on.
Yes, doctor. So I wanted to ask you, I'm a counselor for Romila Palliative Care, Sneha, Mumbai. And we often come across patients, especially in the older category, above 80, where the families are often very adamant that they are not going to disclose the disease. So once they hear the word counselor, they become very cautious. And they almost want us to promise that we are not going to tell their mom or, something like that. And it's very difficult to take the conversation forward because somewhere, we understand that they don't want their parent to suffer and to feel scared. But it's really very challenging. When they say that my parent is very old, we want her to be happy. You can come to our house, but, there's no way we want her to know. So how to handle that?
I understand. Absolutely. We are all in this situation many times. So as I said, we may not have the exact answer for every exact situation, but the best foot forward is to basically build a rapport with the family and then sit with them, actually give them the formal data, as I showed some studies, that this is the people done actual studies in our country or whatever setting it is, that these people really want to know. And why do you think your father or mother is not as strong as you? If you can bear them losing them, and it is actually more beneficial that if they know that they have, yes, of course, I would still, that if the patient wants to know. So there are many ways we can tell them, okay, we won't tell them the direct diagnosis. Let us have a chat with them, and we can, just tell them that there are some, things, good news. Good news is that, we can, you're mobile, you are still clear, you can do a lot of things. And there is some not so good news regarding the illness. Would you want to know? So if the patient is saying, yes, I want to know, then, I mean, the family would probably understand after we have counseled the family with the data, with the benefits, like I said, in different slides, if they have any wish in life, they want to do something, they want to travel somewhere, they want to go to a, pilgrimage or anything, and you will be denying all this to them just because thinking that they will die. I mean, it's a bit of a paradoxical thing. They will lose and they will die unknowingly, but because the fear of not telling them they're going to die, so they'll die in a bed. So all this has to be counseled to them. And my experience is, I'm not a counselor, but sometimes we do end up talking, and most of the times they will want it their way. We have it their way, maybe in more than one time or these things, but before it is too late. And of course, if we, as I keep saying, if you get the chance to talk to the patient and they show a bit of a reluctance, and they show that and you tell them that we have talked to your family and we can keep talking to them unless you want to know, they can talk to you. If the patient tells us it's all right, you talk to them and they can talk to me, then our work is done. Then we don't need to tell, if the patient is giving us the option. So yeah, I know, and this is always a long discussion, and maybe at some point of time we'll have more clarity, more research into it, where we can talk to the patient. But it's a real situation, and we want to have everybody on board. Yeah.
Thank you, doctor. Thank you.
Rajlakshmi, Sunil here.
Yes.
So,
Hi, Sun.
just want to, I was listening to your conversation. So, what I want to tell you is, if you look ethically, we have an obligation to tell it to the patient. But whenever you practice something, we have to put it into the social and cultural background. Most of these ethical principles, these are mainly developed by the Western countries. We know there are 4 ethical principles. It is autonomy is the most superior thing, which is the we have to respect whatever the patient wants. So patient's autonomy is the biggest thing. then comes beneficence, that we should do benefit for the patient, and then non-maleficence. Non-maleficence means minimize the harm. So whenever we do something, we have to balance between this harm and benefits. And if benefits are more, we have to go and do that. Then comes the next principle, justice. There are many types of justice. A few things, a few forms of justice are. One is legal justice. So you have to abide by the laws present in that country. That is legal justice.
Absolutely. I mean, you're right, Sunil. So ultimate is the what we do for the best for the patient, not that I have to enforce my own thing. So you said it absolutely right. We have to modify it according to the need, and sometime by our intuition also, without flouting rules and regulations. Yeah, sure. Go ahead, Genevieve.
Hi, doctor.
If
Thank
I
you for
pronounce it right.
your
Yeah.
presentation. I'm a anthropologist researcher who studies doctor-patient interactions. And
Yeah.
so far we've spoken about families as like this one united front. On the field, like whenever I'm in a hospice, we come across even families not being united when it comes to in the decision making process. So you'll have like one brother or a sister disagreeing with what the course of treatment should be or what kind of palliative care the patient needs. So how do you, at least in your experience, because I mean you're more experienced, how do you handle such situations or scenarios?
Yeah, I can understand. Haven't come across too many of them, but I can totally agree on what. So what Geneva is talking about is that when the next of kin, more than one, have divergent views about it, the simplest thing is that we ask them to do a family meeting. That is what we tell them: go have a family meeting. And of course, the closest family blood relations, the children or wife or husband are the ones which should be making the call. If the patient themselves cannot make a call, they are not competent. Of course, if there is a discord and the patient is competent, no way about it. We have to go talk to the patient. And then we think of other things also: malafide interest. Somebody doesn't want to change the will. Somebody doesn't want to spend money. The the mothers earned 50 lakh and given it to, they think it's coming to them. And now if they spend money, 30 lakhs on the treatment, their whole life, their calculation of using the parents' money will be gone. There can be malified things in this also. Not very common, thankfully, but we have to think of everything. So if we sense there is a discord, because usually the family sit together and then come and talk to us. That is 99% of the time. Openly, we have not seen much that they are discording, the sister saying something, the brother saying something. Of course, in a family meeting, they can tell their views that I used to think like that. The other person said, no, but your father thinks like that, and they will come to a consensus. Very rarely that they can't, but I can understand where somebody is openly, like you taken a call, depending upon, this happens more common is that you take a call. Let's not put the patient on the ventilator if nobody wants it, and patient is not fit for any kind of thing, or they have expressed a wish, and the other person comes and says comes from far and say, oh, you haven't done it, you should be doing it. They don't know anything. My brother doesn't know. He's a simple person. So that is the controversy can happen. So one, you need to talk to the same person again, the whole thing. What was about you talk to the one brother, then you have to talk to the other brother. But if there is a discord, then they need to sit together, and we can facilitate. Counselors can facilitate, researchers like you can facilitate, and ask them. Usually these are more communication issues rather than, they would generally know what their parent or loved one would want in this situation. But if somebody has a real, very strong discordance, which is again very rare, as I said, if you can give me an example, what you exactly felt. But then sometimes we may have to invoke the courts. In Western countries, courts come in very easy. I worked abroad, and many times the court is the care, because people have left, the children have abandoned and gone away or whatever, because of the individual person, not in a family, they already have a court appointed person, and they're the ones who take a call. So we have to work with the court appointed, whether that may be a medical professional, a legal professional, or a general volunteer working on the behalf of the court. That is not very common in our setup, because these things usually don't go to that level unless it's an abandoned patient, then of course we have to go with the courts or the police sometimes. Is that all right? Yeah. All right.
Thank you, Dr. Param. Dr. Sunil, I think he didn't complete his sentence later before.
Okay.
Rajashri, I
Carry on,
don't know
Sunil.
how much did you hear.
So we just heard the four ethics principle you told.
Okay. So out of these four ethical principles, autonomy is considered as the most important principle, which can override other principles. So whatever be the patient's wish, you have to respect. If you look at the Western countries from where these ethical principles originated, all the patients, they are very independent. They go to the doctor independently. They do all the treatment, take decisions, etc. by their own. So it is very highly respected ethical principle. If you talk to even to a family member regarding a patient's problem, then they can even sue you. But I think we have to put the ethical principles into socio-cultural context. So if you look at it in Indian situation, mostly the patients does not come alone. They comes to see a doctor with a family member. That may be a spouse, son or daughter. And this family member will be accompanying the patient throughout the disease. What we have to understand is that we have to also respect the autonomy of the family. So somebody from Romila told that how can be managed if the family is very resistant and the patient wants to hear. It's a very difficult situation. So what will you do in such situation? This is a very common situation that I'm sure those who are working in palliative care faces every day. Even though we understand it is the patient's autonomy is the superior thing, we have to also understand there is some respect that we have to give for the autonomy of the family also. Then the next thing we have to do is Param has gone through how to break the collusion, and if you do it, then some patients, some family members may allow you to speak. Some family members may tell you that we need more time. I want to discuss with my brother, sister, or somebody else, and then we will come back. Somebody else may not agree at all. Even if they will tell you, we understand, doctor, or so and so, but we don't want to communicate. We have to prepare for all these situations, and then if they don't then allow us to communicate, then we should ask the family. The patient is asking us, and if I don't answer it, the patient will not trust me. And suppose if you are my patient, and if you ask me something, and if I don't answer, will you trust me? They will understand the situation. Then you can ask or tell the family member, if they ask me again, what should I tell? Then they may tell you that, okay, don't tell that it is cancer, tell it is something else like ulcer, etc. But we are sure that we have to communicate that we are not going to tell any lies to the patient, which will again be a communication barrier. So we cannot communicate like that. We have to tell the truth. So you have to now. It's your responsibility to tell us uh, what should we do when the patient asks about the um, disease. That will tempt them to allow us to communicate the news to the patient. So this is what my experiences. So just want to highlight the importance of the ethical principle autonomy, not only of the patient but also of the family. And there is also another factor that the deceased or died patient will not go to the court to sue us, but the living family member will be the person who is going to the court to sue us, because they may go to the court and tell us we told them that this should not be done, but they have done it. This may not be any problem in front of the court, but still we have to go to the court and things like that. So I think it is always better to take the take or we should be beside with the caregiver or family member uh, to do whatever we want. So please take them into our side if we want to communicate or if we want to do anything with the patient. Thank you.
Yeah, thank you, Sunil. Yeah, that is, I can understand. We all go through this situation, and you never know what is the best sometimes. So we have to go, as I said, the most ethical possible and without breaking the law. Of course, family is very, very important. I'm not sure though whether the fear of court should keep us from doing the what if we strongly feel it is the right thing. So maybe in your situation, what you were saying, and you have a very legitimate case regarding that, if the family is so resistant about telling, what we can try sometimes doing is that just at least inform. So your obligation is, when we're talking, even when the family is there and the patient is there, you tell them that I have discussed with your son all the things, and we are making a plan. They have told me the inputs and all. So at least the patient knows that things have been talked, which to privately to the family. You don't have to say it in so many words, but we need to tell them that we have had a detailed discussion about your disease and planning, and you can talk to them, and you can then, if need be, you can come and ask more questions, something like that, in a bit of a gray area, where the patient gets an idea that something is being talked. And if the patient doesn't want to feel good, doesn't feel good knowing, they get the hint that they can always keep quiet and not go and talk to their family. But if they want, at least they know, if the patient knows that there is a discussion going on. So that is not a very difficult thing to do. If you are wanting not to antagonize the family, at least in the patient, you tell them that in a matter of fact manner, that there are reports and there are things, and your family says, since you are on the bed, we have had long discussions and we've made good plans for you. You can have a discussion with your family. And if the patient is suspicious and they actually wanted to know, they will probably talk to their family. And if they're not convinced, they may come and ask us. So it's probably something like a midway thing in between, if you are stuck and you don't want to, be anything against the family.
Thank you, Doctor.
Another thing which I want to tell you is fatigue. So whenever the family member or patient or whoever, it may be in emotions, patient is crying or angry or whatever it might be, any emotions. The first thing we have to do is just wait for the emotions to wean off, and then we should we should tell a empathetic statement or empathic statement. So if you ask me what is an empathic statement, is you can make an empathic statement by naming the emotion and the reason for that. Suppose the patient is crying after hearing the bad news. You can tell the patient that you are really worried because really worried due to hearing of this news. Whenever we tell this to somebody who is really worried or crying, then they will understand that we are really concerned about them. So that's the aim of this empathetic or empathic statement. This is the most important thing in when you face somebody with an emotion. Thank you.
Yeah. All right. Yeah, good. Yeah, good inputs. Thanks. Yes, and that is how, if there's two people doing, it's always a good discussion happening. So yeah, this question is going to remain in the end about disclosing, and we'll keep discussing it most of the time. So maybe we can do an exercise. I mean, if you want, you can put it here in the next 2 minutes, that if one of us sitting here had some kind of a serious illness or maybe a terminal illness, how many of us would not want to know? We are part of the society. We may be doctors or medical professional, counselor, researchers, but I mean, just curiosity's sake, how many people here would really not want to know and go blindly without knowing that you are going to go? I mean, personally, I would want to know very much. On as soon as my doctor knows, I would want to know. I mean, but basically, it's a very, very individual thing. I'm not asking anybody to go by that. Just a question in my mind. I've never done this before, but it may be easier for us to say. Maybe when the actual threat is there and there is, I think my PET scan is being done, I may not want to know. But I think if I would, I don't know. I will probably come out of the PET scan and first ask I'll be very scared. I'll be very, very these things. Not really sure if there'll be a situation I would possibly, but maybe being in the communication thing. Sunil, what would be your input into it?
So this is a question which I usually ask before taking this class, and most probably we are talking to even if we talk to laymen, most of them want to know. Almost all, maybe 100% want to know, and there will be 1 or 2 who don't want to know. Uh, then we will ask. Usually, we are the caregivers to somebody, and we don't want the patient not to know about the diagnosis. But if we have the disease, we want to know. So this is the paradox which usually occurs.
Absolutely right. You hit the nail on the head. If you ask the question differently, and if you ask everybody here that if somebody very close to you has some sort of a thing, would you want them to know or not? I think the answer will be a little different. And maybe because we are all educated in this, the answer will not be representative. But you're right, Sunil. A lot of us may think very deeply. Right now, we are just saying, oh, I want to know. But if the same question is about somebody close to you, we maybe take a careful. I don't know what I would think. I would probably think that my approach that let's have a casual conversation, trying to know if they want to know. A lot of elderly people come and tell us, no, don't bother me. Just talk to my son or daughter, or they will talk to me, probably because they don't want to know. But that is a minority according to me. But your paradox is very well understood, Sunil. So maybe we need to think more on that side. Absolutely. Sameer's got a very nice point that this paradox can be discussed. So, but to tell the patients that actually you feel that we are strong and are what makes you think that your kin are not strong? If you were in this position and you would want to know everything, maybe your close one also deserve in a course of time. Don't have to, as I said in the first slide, you don't have to run after them to hit it on their head. But some point of, especially if it's a terminal thing, then I would seriously think that I don't know how many people would be happy going without knowing. Maybe there'll be some, not too many, I guess. I guess I'll have to end. I have to hop on to another meeting. Thank you so much all for the interactions, and we keep thinking and learning, all of us together. Thank you for your inputs, and I think they'll
you,
be
sir.
useful for me too.
Thank you, Dr. Para, for that excellent 2 sessions. Gave us a clear idea about how to communicate and why is it very important in palliative care too. Thank you for being with us for the 2 sessions. Thank you, sir.
Sunil, you can continue if anything more points. Yeah.
Uh, yeah, thank you, Param,
All
for
right.
joining
Bye,
us.
Sunil. Yeah.
See you
Bye.
for another session.
Yep. Bye-bye.
If there are any more questions, I can take it.
Any questions? Sir, I guess it's a no. So can we have a case presentation and then come back to the discussion?
We have a case presentation.
Yes, sir, we do have.
Okay.
We have no, Rajni and I are taking session. Case presentation now. Over to you, Rajni. Rajni, we can't hear you. No, we can't. I think there is some. You're muted, or you are you using a headset?
Okay. Can you share this? This case was of a 70-year-old male who was diagnosed with a nervous system disease, and he's completely bedridden, and he's unable to. He's lost his speaking abilities, and he's able to communicate. He used to communicate by writing, but currently that he's not able to hold the pen either, and he's on ventilator since January this year. The families. Okay, how do you? So the information was given to me by the wife and his 2 daughters. He was since past 9 years he was in the USA, and after being diagnosed with ALS, he had returned back to India in November. Then in January he had some breathing issues for which tracheostomy and PEG was done, and completely bedbound by now, but fully alert. He has lost his speaking ability and could convey by writing. Yeah. Next slide, please. So the patient is not aware about the diagnosis. His family members know that his is a progressive disease, and the patient is not aware of the diagnosis nor the prognosis. The family members now feel that they should not have opted for the ventilator because the quality of life was going down. So the patient, sometimes he is able to talk. Sometimes he is able to write, but not fully. He's losing that capacity also. And the family now wants to tell him about his options so that they can let him go peacefully. So the family overview, they have 2 children. The elder daughter stays in Mumbai. The younger one is based in the USA. All his siblings and as well as his wife's siblings, they are all settled in the USA. So no, the other extended family members are not staying close by, and they don't have friends or family either. So he's very attached to both the children, the daughters. So this is the overview. His wife is the primary caregiver, and the daughter is very supportive. The elder one, she visits them every day. The wife, being the caregiver, she is very stressed out and is ignoring her health as well. So they have exhausted all their savings and are currently financially supported by the children. So he was not very religious. So there's no support from religious institutions. Since he moved back to India just in January, they have lost all their old friends. They have moved out. So no friend support. And recently they moved to a new house. So neighbors are also not known to them. And his children are there. The palliative care team is there. The general physician, they have good relations with them. His elder brother who stays in the US, they have some tensions within them. So not very close. So this is the socio-economic overview. They stay in a 1 BHK rented house. They have exhausted their earnings and are dependent on their children. The family initially was staying in his brother's house, but have moved out because they feel that the extended family is not very comfortable letting them stay there. So the psychological assessment of the patient was not possible as he was, there were some issues with, because he can't speak. There was some, initially there was some problem with me trying to talk to him, but then gradually as I was able to establish communication, and he has communicated that he never wanted to return to India and that he was aware that, and he didn't want to know about the prognosis. He's aware that he's on ventilator. So yeah, he's completely bedridden on ventilator, unable to hold the pen. Then socioeconomic needs, they have financial issues, no close family around, extended family support. Wife is also a senior citizen with her own issues, health issues. And yeah, psychologically, he has a lot of crying spells and aggressive behavior at times. He's not very religious, so no support from the socialist religious institute. So the discussion point here will be, how has the illness impacted the quality of life of the patient and his family members? The ethical question as well as legalities also that arise if the patient is unable to understand or not wanting to know the prognosis. Keeping in mind the quality of life of both the family members and the patient, what could our priorities be?
Thank you, Rajni ma'am, for that presentation. I think by now you are very clear about what to be communicated and what not to be communicated. So, like I wish to get the inputs from all the participants on their suggestions on these 3 questions. You can either unmute from your end and speak or give your inputs in the chat.
Am I audible?
Yes, you are.
Good evening, everybody. This is a very sad story to hear. I think the main issue here is the patient has a motor neuron disease. And as we all know, it's just a question of time and how long the patient can be supported financially in the present situation. So what occurs to my mind is essentially how to keep the patient alive and keep him going, because ventilators are expensive and I mean, it's an indefinite prognosis because in a permanent vegetative state, nobody really knows. So what would be the, like you said, the ethical questions here would be, as I see it, is can we keep this patient going indefinitely? Who would support? Would the government take any responsibility? Would a ventilator be provided at any palliative hospital close by where he could be, at a subsidized rate, or what the patient could go on with? Of course, it is difficult considering that the children are also abroad and most of them would not, I don't know whether they would be able to provide funds for this patient. So these are the questions which come to my mind. Thank you.
Thank you, Dr. Agini. Rightly said. Sunita ma'am have shared the total pain is huge for family, especially his wife. Palliative care to focus on weaning the patient away from ventilator if possible. Sarita has commented like the caregiver is terribly stressed physically and emotionally. Luckily, the children are able to support her. Dr. Sunal, your input, sir.
This patient, we cannot call it as a vegetative state because patient is conscious and he comprehends, even though he is unable to speak. So this is not a vegetative. This is not vegetative state. Uh, this disease, motor neuron disease, which particularly affects the muscles, so that movements will be affected. Uh, so you may not be able to speak, you may not be able to swallow, and even it will affect in this patient. It has affected the muscles for respiration. That's why this patient is on ventilator probably. So how much it has affected, I am not sure. Uh, if I think the most important point here is which we usually don't do in India is whenever the patient has some serious disease, we should uh, discuss with the patients and families to come up with an advance directive. So in the advance directive, we will discuss with the patient regarding what are his values and how would he want to take care of when he face some situation, and who will take the responsibility if he is unable to communicate his wishes, etc. So that this should be done at an earlier stage of the illness. So when the patient is unable to communicate anything, then either there will be something written as form of advance directive, or if or the surrogate or the family member who is designated as surrogate can modify this according to the wish of the patient. So this is what we should do or we should practice. But sadly, this patient has ended like this. We don't know what is the wish of the patient. So I think it is important to understand what is the wish of the patient, and as this patient can understand what we are speaking, and he can even communicate to us by his thumbs up and downs, and if he is able to move his eyelids, maybe eye closed eye and open eyes. So those all are modes of communication. Uh, I think it is important to talk to him regarding this and get we should understand what he wants, and even the quality of life. So all of you might definitely this patient's quality of life is seriously impacted, but what we have to understand is quality of life is not decided by us. Quality of life is decided by the patient or by every person. The quality of life for me will be different from quality of life for somebody else. So it has to be actually we have to talk to the patient and have to decide what is the quality of life of for that person or patient. And yeah, ethically, I think I don't know, but sorry, I forgot who presented the case.
Rajni ma'am have.
Okay. So, Rajni, can you tell me what ethical questions do you think is in your mind?
Yes. For one thing, when I asked the patient if he knows about his disease, or he said he doesn't know, and I asked him if he wants to know, he said no, he doesn't want to know. and his family members are saying that they want him to know because then he can have then he can take a decision, informed decision about what to continue or not. He's aware that he's on ventilator, but he doesn't want to know about the prognosis and what disease it is.
Yeah. So, uh, uh, if the family member are also with us regarding exploring the insight, then I think we should go and explore the insight because we tell that a patient has the right to know about the diagnosis. So uh, we have to actually explore it, but in this patient it will be difficult, but we should be able to do because you have told that you have communicated many things with thumbs up and thumbs down. So we should be able to communicate with this patient and find out his insight, and also with his consent uh, we have to yeah sorry, I am traveling, so that's why the disturbance is here.
Okay.
So with the patient's consent and family's consent, we can break the bad news to the patient.
So my question was, if the patient is not wanting to know his prognosis, then how do we break the news to him? If he has flatly
So it is very simple. Even if the most important thing is, it is the patient's um, right to know, but it is not their duty to know. Okay. So if somebody says I don't want to know, it's they meant that. So we need not break that to the patient. But I also understand your concern that then how do we take the decisions? Then I think maybe his one of the closest family members would be the decision maker.
Okay. So we have a Mumbai palliative care network. So
Yeah.
we have written to the ethical committee also for guidance. So they
Mm.
also suggested that the autonomy of the patient is important, and we can guide the family with end of life care plans.
Mm.
So currently, so since he was having crying spells and all, the family has checked with a doctor, and they are giving him antidepressants. So they said after 10 days, maybe we can once again try and talk to him, and then maybe they will decide.
So they are thinking that the patient is depressed.
Yes.
Okay. Yeah. That is one of the possibilities. And but I think 10 days would not be enough because antidepressants will take at least 3 to 4 weeks for to get a good symptom control. So that might be the good time. That's what I believe.
Okay. Yeah. Thank you.
Thank you, sir, and thank you, Rajni ma'am. Anything more you want to ask, sir, Rajni ma'am?
No, that was it. And I wanted to know if there are any legal, I know that euthanasia is not legal in India, but if some patient or his family wants to have a peaceful death, so is there any legal things that legally any options are there in India?
Euthanasia is not legal in India, and there is a problem here. The Supreme Court has come up with something called passive euthanasia, which is not usually used anywhere in the world, but previously they have been using. What Supreme Court meant by passive euthanasia is that stopping food or fluid or medications for a patient when it is futile. So actually, this should not be called as passive euthanasia because euthanasia is always active. There is no term called passive euthanasia. When food or fluid or medicines are not giving any benefit, as a doctor, we should stop it because it is not going to benefit the patient and it is going to cause more harm to the patient. So it is not euthanasia, but this is our Supreme Court has called it as passive euthanasia. And if we stop food or fluid, but in this patient, it might be something different because he is very much conscious and but he is unable to maintain his respiration as his own because of muscle paralysis. So I just want to know that if you know the difference between euthanasia and passive euthanasia. Passive euthanasia is not a word that should not be used. There is only one form of euthanasia. It is active euthanasia, where somebody is taking the life of a patient deliberately with explicit consent of the patient.
Thank you, sir. Any other pressing questions regarding the topic to sir? I guess there isn't much questions. If you still have any questions, to write to us. Sir, you want to contribute anything, sir?
Yeah, I just want to ask Rajani, suppose this patient after 1 month of treatment with antidepressants, even then he says, I don't want to hear about the prognosis. Then you have to think what you are going to do with the, because you will not be able to get his wishes.
Yeah, he has spoken to the family about this. They said they will abide by whatever he decides. So they are willing to accept whatever he decides, but they just wanted him to know what his options are, what his options are. Yeah.
Okay, thank you.